How's everyone doing? This lecture is going to be on squat mechanics and assessment, how it correlates in HPHP to your flexibility tests and some of your strength tests. The big idea behind this is also when we're doing our sit to stand or tug test or any test where we're doing squat mechanics, it's important to use our observational skills as that can dictate towards the treatment that we're going to provide. So, the big question is, why do we squat? And we can see in everything in our daily life, squat mechanics come into the play. You can see, going to greet our child, to getting out of the car, to picking up a box, to childcare, to gardening activities. We are squatting every day. And the word squat isn't synonymous with that. It's daily activity. This old gentleman in the right-hand corner here, he doesn't think he's squatting, but he is. And you can see he has an attachment on his door to help assist him out of his car from that squat position. When we use the word squat, it almost is a trigger at times for people to be fearful of a squat, and yet they do it all day long. So what do we need as therapists? We need to train people how to squat to be successful in the squats that they do. So the big question, why can't our patients squat? And, babies are great examples here. Babies have great mobility. Their joints are super loose, they're super plastic, and babies have to gain their stability. Over time, babies will roll to initiate their core activation. They'll come up to sitting. That sitting posture will strengthen their core even more. Eventually, they start pulling up on furniture, which essentially is training their legs. And eventually, once they're erect in gravity positions, they really strengthen their muscles. And you will see children really squat down in the most perfect form. So they're great examples to look at what a squat pattern should be. And this highlights a little bit of that as well. But we do want to keep in mind, when we look at squats, we want to kind of look at mobility versus stability. Those are your two key factors that you definitely want to consider with that. So mobility components of a squat. So we really want to break it down from the ground up. So you want to get your patients with their shoes off, and you really want to look at what their feet are doing initially. Now, calcaneal eversion and pronation is the mechanics of the foot. Now, someone who has a supinated foot, a cavus foot, a more calcaneal inverted foot, if you think about how that transcends the ground reaction forces up the knee, you're going to get genu varis there. You might get more external rotation of the hips. So the foot is the first and foremost thing that we're going to look at in the squat pattern. In red there, you see ankle. Dorsiflexion is a key component of squat. Without dorsiflexion, it transcends forces in an uneven way. And this is the big one when you have people with knee pain, especially in that patella region, patella tendon component. When they squat, they're pitching a little bit forward into their knees. So instead of the pressure being absorbed through the posterior chain, it's really coming through that patella tendon. So dorsiflexion is a big one you want to remember. The knee obviously has to go through flexion, and we do look at tibial internal and external rotation. Now, not a very important fact here, but ACL reconstructions do lose the inability to actually have some tibia movement. So if you have an ACL reconstruction patient and their squat pattern is a little dysfunctional, they're having some pain, you definitely want to kind of be mindful of the tibial rotation that's there. Obviously, with a squat, you need to have hip flexion and you need to have external rotation. And that's extremely important in the lowering phase. And external rotators are typically tight and limited, so we do look at that as a component. If they do have some hip OA or their hip is not in a proper alignment, you could have limited flexion there. And then obviously on the upward phase, hip extension, internal rotations are a key factor. You're going to see when we talk about the upward phase, what muscles are activated in the upward phase. And then obviously we need to talk about the lumbar spine. You got to remember the lumbar extension and sacral flexion is a coupled action. The same with lumbar flexion and sacral extension is a coupled action. So you have a misfiring of that coupled action, let's say because of a non-ament or some kind of restriction in the sacroiliac joint, that can definitely cause a difficulty in the squat pattern and also cause the back pain. And lastly, we do need to have some thoracic extension. We do know that posture is a big thing within our population. They have forward shoulders, they have a forward head, they normally have a weak shoulder girdle with protracted shoulders. So the thoracic spine does get locked up and gets limited extension. And we can consider this as our population does have a very prolonged sitting time frame with computer work. And as students, you guys can correlate to that. You sit throughout the day, you're on your iPad, sitting posture definitely gets inhibited. And you notice a lot of you guys will lean back, stretch your shoulders out, crack your back. So you can definitely consider that the mobility there is a component of the squat pattern. So let's consider the stability components of the squat pattern. All right, so ankle stability is a big component. So like we said before, from the ground up, pronation is a big thing you want to look at, excessive or limited. Excessive pronation will put genu valgus into the knees, and limited pronation will cause genu varum in the knee. And if we have that occurring at the knee, we have to ask ourselves the question, what is driving the forces? And you can see that in the knee stability component. Is it from the hip or is it from the ankle and foot? All right, and we kind of say that because the hip stability is a component of what the Q angle looks like. So one thing to remember is as girls go through puberty, their hips do get wider, their pelvis gets wider. They may have an increased Q angle. They may have more internal rotation. And women overall will have that presentation more than guys. However, guys have more musculature in the hip. Their hip external rotators may be overdeveloped or overengaged, and then they might be walking with a toe out pattern, which also puts stress and strain into the hips and into the pelvis and can disengage the squat pattern. Core stabilization is a big component. We're going to go through that. And I'm going to show you what that looks like. But we do have to have pelvis nutation or counter nutation during upwards and downward phases of the squat pattern. So if the pelvis, the sacroiliac joint, or the lumbar spine does not have enough stabilization to cause those movements, you cannot get into a squat pattern without having dysfunction there. And then, of course, we talked about this a little bit in the last slide. If the scapula are protracted and you have scapular instability, you will not be able to kind of get into your thoracic spine to stabilize to go through that motion. And I do like that little picture, and we always talk about this, the knee falls victim to the hip and ankle. So if you have knee pain, especially with a squat pattern, you will definitely look more in depth into the hip and ankle of a patient. So this is where we start kind of putting in the aspect of like, what's the lowering phase look like of a squat, and what's the upward phase look like in a squat? Because when we assign squat as an intervention, we have to consider what's more important, the upwards or downward phase. And we're going to look at some muscle activation in this. EMG study is pretty neat. If you look on the right-hand side of the slide, you can see you have partial, parallel, and full. And so the discussion is always, well, partial squat doesn't mimic the function. A parallel squat may or may not mimic function, and a full squat is what we need to achieve constantly. And so in essence, this study shows that at times, certain muscle groups may engage with a partial, a parallel, or a full almost in equal lengths. But the important thing is when we start talking to our patients about squats can be fearful. So here we are talking about we're going to do some partial squats. And we have to remember that even with a partial squat, we do get great muscular activation. And so when we look at the lowering phase, we do have multiple muscles that do kick in. The ankle, the triceps suri, or the Achilles tendon components, they have to eccentrically load. So someone who has poor strength levels there, let's say they just came out of a boot or an ankle sprain, may not be able to squat because they can't absorb the energy. So dorsiflexion looks good, range of motion looks good, but they can't eccentrically elongate that muscle yet, and so they have difficulty with the lowering phase. Obviously in the lower phase, we have eccentric activity of the quadriceps and eccentric activity of the hamstrings and adductors. The hip, we definitely have eccentric activity of the glutes, and we have to remember that the glute minimus and medius do stabilize the hip as they go through these movements. And then eventually we do have our core that does allow eccentric activity, because otherwise gravity would pull our trunk forward. The upward phase, and here's your EMG report again with partial, parallel, and full. And so when you look at the upward phase, we want to lock out to the top. And if you can see, when you do a full lockout in the upward phase, which is not going to hurt, anyone's joints, you get great gluteus maximus activation. So we definitely want to cue someone to come all the way up to the top. You know, when we look at other structures, vastus medialis, vastus lateralis, if the quad is a primary function, before they lock out of the top, maybe we do work in a partial range because we're going to try and stay in mid-range and get great activation of that vastus medialis or vastus lateralis. So we can consider modifications, not as a height of the table, but sometimes just if we're going to stop them and start them in a certain say. So simply put their hand on their shoulder and say, stop there, go back down, have them come back up, and you kind of limit their squat pattern to some degree to get some different muscle activation. So we all know this on the upward phase, the knee, on the concentric action is the quadricep. The hip is the glutes, and the core activation of the paraspinals come to play in the upward phase. And so we talked about this a little bit, training the squats. Does it matter if it's partial squats or full squats? Partial squats can still yield significant activity, all right? And we also have to consider this, is look at the activation for the hamstrings and the glutes. That is your concentric movements. Your vastus medialis and vastus lateralis are really your eccentric movements. So we want to make sure that when we're targeting these muscles, we're targeting them with the correct muscle activation as well. And then we do consider this, what impairments do we need to address in the squat mechanics? And we're going to go through that through your assessment so that we can target exactly what we can hit on. So before we go into squat evaluation, we always want to ask these questions. Where is the pain when squatting? Is it at the knees? Is it at the hips? Is it the back? And kind of get some kind of focus on where that pain's presenting, because it may cue us up on what structures we're going to look at. And that creates the other thing, is what structure is causing pain. And this can be specific to the structure, but we also got to consider referral pain. So the big question though is, why can't a patient squat that is leading to pain? And so I want you to kind of get your mind around regional interdependence, which means there may be some pain occurring in an area from a dysfunction elsewhere. Okay, so that's one thing you want to keep in mind when you look at this. I don't know how many of you guys have been exposed to functional movement screening, but functional movement screen is a great way to somewhat organize and analyze a squat. So if you see, there's a scoring system with FMS. 0 is pain, they can't do the thing at all, so you score them a 0. 1 on the bottom there, you can see, even with their heels on the board, they still have a very dysfunctional pattern. They basically have a trunk lean that's still present there. And so, you know, it's very small alignment, but sometimes when we see that trunk lean, even with the heels on the board, we are going to start considering maybe the rectus, maybe the hip flexors, or maybe even the lats are pulling them forward, and that would be a further evaluation. A 2 is scored typically when the squat pattern improves when the heels are on the board. And so what that does, it removes dorsiflexion out of the equation. The squat pattern looks good. So the answer, if someone scores a 2, is let's hammer out their dorsiflexion components, so good calf stretching. And a 3 is a perfect squat. Great alignment, dowel rod stays overhead, knees go past parallel. So we definitely want to consider what are we looking at on a mobility or stability component. In some essence, the first thing is always looking at the mobility aspects. And so a 3 and a 2 pattern, we know they have good stability. A number 1 could be is where we start seeing mobility, but we have to consider stability as a source of their dysfunction. So we definitely want to consider that when we do a squat pattern with the FMS system in place. And you know, you don't need the FMS system in place to really check this. All you need to do is get someone's heels propped up on a board and see what their squat pattern looks like. And it could be a very easy way to evaluate and treat someone. Considerations for squat assessment. So we talked about shoes versus no shoes. I will tell you that I would say no shoes is the proper way to evaluate the patient. Now, the only time you may want to be in shoes is if the person has a heel left in place because they have a leg length discrepancy, or they have custom orthotics or inserts in their shoes because there already has been identified that they have a pronation or some foot mechanics that is dysfunctional, and therefore you do want to have their shoes on so that you can see their squat pattern with the correction already in place. All right. Simple, you do not coach the movement. You're going to give them these instructions. You want their feet to be in the sagittal plane, no out turns of their toes. You want them to be in alignment with their shoulders. The dowel rod simply placed overhead, and you want to tell them to slowly descend into a squat the deepest they can, keeping their heels on the floor, head up, and chest facing forward. And so you do not coach them with the movement. You do not give them corrections, and you have to perform it 3 times. We want to observe natural, normal movement. And I will say that you do not want warm up with this. You want to see someone nice and fresh that is just coming into the clinic. You don't want to warm them up. You don't want them to stretch. But the power of this is the test retest. Do a squat, do some intervention, do a squat again, and see what happens. And I'm going to show you some videos about that in a little bit. Some tips also is we want to observe from the front and side. All right, and we do want to ask them where was pain or where was discomfort as we go. The next part of this is SFMA. So SFMA is really for the licensed clinician. It doesn't have a scoring system like the FMS, but is mainly an observational component. And so what we consider is if we look at a simple flexion pattern, we have to start considering some breakouts. And breakouts are the way that we can diagnose where the impairment's coming from. So the first thing that someone would do after doing a squat is we would have their fingers behind their neck to do a deep squat. So essentially not have their hands overhead. And so we do this to kind of figure out, is the dysfunction a little bit more in the upper extremities, such as your lats? So we know the lats attach into the humeral component and come down and attach to our low back region into the thumbro fascia. So right in that region, if you get some tightness, it's going to cause you to trunk lean. So we do that instantly to rule out lower versus upper quarter components. The second part of it is considering whether it's core stability versus a lower quarter problem. So this is where we start getting into stability and mobility. So we simply would have them, we would hold onto their hands and have squat again. And so we're unloading the ability of their trunk to take that control. So we definitely take a look at that to see, do we have a good squat pattern? If the squat still looks bad, then we move on to the mobility components. And so the most common problem is the ankle. So you can see here, this is Gary Cook. Gary Cook is the person who has designed FMS, SFMA, and he's doing what they refer to as a half kneeling dorsiflexion test. So if you had this in your clinic, you simply would put a ruler 6 inches away from the wall, have the person's toe right in front of that line, and see if they can drive their knee into the wall. So if they can pass 6 inches of their knee over their toes, typically dorsiflexion is negative. Now, if they can't, then you have to do dorsiflexion. The nice thing is what he's doing there as a test is also a great intervention component. If they still have dysfunction, we do consider looking at their knee mobility, which is the supine knee to chest holds to shin. And then we look at the hip mobility, which is the supine knee chest holding the thighs. And this is how we can start actually looking at mobility versus stability. So to review, fingers behind the neck, we're kind of ruling out upper and lower. All right, so we can consider lats. Loaded and unloaded. So we unload the person's body and look at the mobility of the lower extremity. The mobility looks good. It's going to be strength. Dorsiflexion, knee flexion, and then hip flexion. So this is what we talk about loaded versus unloaded. At the top here, you see on the left, that's my tech Chris. And on the right here in the red, that's my tech Sean. So both are laying down doing a squat pattern. And you see they look pretty equal and symmetrical. So then what we do is we have them stand up and do the squat pattern. And you can see my tech on the left, Chris, has a perfect squat pattern, but my tech on the right fails to go below the knee in 90 degrees. So then what we would consider is it mobility or is it stability that's causing his issue? So then we take him to the TRX straps, which is a great way to unload him. And you can see he can definitely dive down deeper once he's kind of in an unloaded position. So essentially, we need to kind of improve some component of stability there, whether it's eccentric loading into the hamstrings and glutes, whether it's core stabilization, but we may actually consider both as a factor of his treatment, mainly to correct that pattern. And here's a variety of different mobility and flexibility impairments. And so some soleus stretching, gastroc stretching, foam rolling, that we would be working into some back extensors and some hip mobility, hamstrings, rectus femoris, Thomas stretch, different ways to get the hip flexor involved and on dynamic level, hip external rotators and foam rolling, and then some thoracic mobility. This is a very interesting concept. So I will highly encourage you, if you have an interest in outpatient, to seek out a certification in SFMA at some point in your career, if not earlier than later. It is such a great way to organize your evaluation skills. But one thing they talk about is rolling as a way to reestablish the core and engage your paraspinals and your anterior core, your corset, your transverse abdominis, your obliques, and your rectus abdominis, mainly because of the neural patterns we develop as a child. So where this comes from is what I talked about earlier. Babies will first roll. The rolling is a component of their core engagement. That core engagement, if it doesn't occur, they'll never be able to prop up into sitting and hold that posture. And eventually, if their core is not established, they can't come up to standing. And if the core is not established, they will not walk as well. So this brings us down to think about this. When was the last time you rolled yourself? And then when do you think was the last time your 60 to 65-year-old patient or older got on the ground and rolled? And more than likely, they probably have never done that in a very long time. Now, of course, in bed, maybe they do roll, but you gotta remember, when we roll in bed, we are using tons of assistance with our upper body, momentum, lower extremity, all that. So this purely is a test to see if we can engage our core to roll from our back to our belly and our back and our belly to our back. And so simply you can see up here in the left-hand corner, she is using her leg as a driver first. So she lifts her left leg and tries to roll herself over without digging her arms or hands in the ground, and rolls onto her belly. This one right over here to the right, she's basically doing the opposite. She's raising her left leg up in the air and using her extensors to try and go from back to belly. The bottom right over here, she's using her upper body as a driver to bring herself over. You don't use momentum with this, you don't put your heel, but then you try and roll onto your stomach. And the same way she's using her upper body here to roll onto her back. So simple instructions typically is you're paralyzed from the waist down, or you're paralyzed from your waist up, just so they realize they should not use those components. And it's a great way for core engagement to realign a squat, to re-engage an extension or flexion pattern that's dysfunctional, a great way to get some core activation in a very easy manner. So this is something I will highlight for you to guys get on the ground, try it out. You're gonna realize you get stuck when you attempt to roll. And this could even be for your very athletic type, because you remember your athletic type trained for the sport that they do. And if they're not cross-training holistically, they may be losing some aspect of this. So you will be surprised on who actually gets stuck and who doesn't. So I challenge you guys all to try this. Lastly, here's some stability impairments. So you can see some bird dogs, some bridging, some planks, side planks, wood chops. Obviously, we're training the squat with a ball behind their back to give them proper alignment versus allowing their body to do that in gravity and space. Single leg stuff, hip abduction, lunges, so tons and tons of different options from a stability side. But your target areas are going to be the glutes and it's going to be the core. And what you want to consider is training in all those planes of motion. If we think about our abdominis, our rectus abdominis and our paraspinals, they work in that sagittal plane, or our obliques and our transverse abdominis is working in that frontal and transverse plane. So to work the whole core, we have to work in all planes of motion. Our hips, they work in flexion, extension, and internal and external rotation. So all planes of motion are being played on there. So definitely consider your training protocols to consider all those actions. So here's some of the fun parts. We're going to look at some videos. So this first video batch is a bunch of high school students. And so what's really neat about this is this was a set of students who did a capstone. And so let me pause this real quick. So These students did a capstone. What they looked at is inter-class reliability of testers. So they played these videos for numerous people and saw, does everyone score them the same? And if you remember, FMS scores on 3 is perfect, 2 is with the board underneath their feet with a perfect squat, 1 is not able to do it with the board, and 0 is because of pain. So very simple scoring rater, but with that being in mind, does everyone score the same way? So this first kid here, and then he's first and foremost, because his squat is not that great. So I want to back it up a little bit, replay it. And I really want you to watch this thing. This is a high school student. I think he was probably 14 or 15. And you can see a lot of going on there. Heels are coming off the ground. Knees are coming all up. He's wobbly. You know, he has some hard time controlling his descent. So he definitely didn't pass that one. So now we're going to put his heels on the board. All right, he gets onto that thing. Bring the dowel rod overhead, and then we're going to have him go ahead and squat down again and see what happens here. So he still is not perfect here. Now it's better, all right, but it's not perfect. So one thing is we obviously know that his heel cords are tight, all right? So with tight heel cords, we want to attack that first. Obviously, once we attack that, we have to dig in a little deeper. We saw there was a lot of neuromuscular control with that knee when it was moving. So we probably are going to start considering, what's his Eli test look like? What's his Thomas test look like, first and foremost? Does he have a tightness there that's pulling his trunk forward? If those are negative, then we are going to be in the mindset of strength, because he doesn't have a flexibility component driving him to be forward. And I will say this, and don't quote me on this, but it's a little bit of opinion. Flexibility wins over strength sometimes. Flexibility has more powerful components at times. So you always want to leave it mobility, and that can be a component of tissue components or joint restrictions. So mobilization, soft tissue work, flexibility and stretch should be always a go-to first if you're trying to correct movement. So we're going to go to the second guy over here. We see him come down and squat, and you see those knees wiggle all over the place, in and out. So obviously that is not a passing score there. So we'll get this guy to get his heels up on the board there. Get that dowel rod back overhead. And we're going to have him squat down. Now, I will say, if you watch, his knees are doing well. You can see when he eccentrically loads or goes down in that lowering phase, his legs were bowing out. So we can notice that on observation. He definitely cues into his external rotators as he goes down. So part of me considers that a compensation, that he can't control it with his trunk. So with him, we know that dorsiflexion definitely was the first deficit there. The second one is that external rotation coming out. Maybe we have to stretch that. Maybe we have to get some core stabilization to kind of counterbalance that. So that would be target areas that we would focus on next. Now this guy is interesting. His squat pattern is all about the trunk leaning forward. And you see that completely with his squat pattern. Knees don't move, no external, internal rotation, pretty solid in his squat, except his trunk is leaning way forward. Simply get his heels out on the board, comes down, much better. You know, now he still doesn't break parallel. There he goes, he breaks it there. And sometimes the first time they don't, and breaks it there again. So he is simply a class of just dorsiflexion. Now, you instantly see when this kid squatted down, his legs are externally rotating out. That's pure compensation of a dorsiflexion restriction or a flexibility restriction in that level. So first and foremost, I want to get him with his heels on his board and just see what happens. I have a feeling he probably needs to stretch that area. Much, much better after he did that. You see his knees are still going in and out, you know, so even with his heels on the board, he may still need more aggressive dorsiflexion outside of stretching. And you do have to consider this. He's a very tall young man. I don't know exactly his age, but these are high school kids between 14 and 18 years old. the growth spurt that he most likely had at this time is going to cause his muscles to lengthen shorter time frame than his bones. So basically, you will see tons of flexibility deficits here. More than likely, he probably has either some hamstring or some rectus tightness that's coupled with the dorsiflexion tightness. And in some instances, I would say based off his posture, and we're looking at his lordosis here, that he probably has a little bit more of a flat back. So his hamstrings are probably much tighter because we can kind of almost see that his tilt is more posteriorly present. So I would say that his hamstrings might want to be looked at. So here's another one. So these are volleyball girls, high school. Now, girls typically will mature more in their body quickly. So their pelvis will kind of widen out. They'll kind of build into their body. So you will see injuries in female populations typically between 10 and 14 years old when they start hitting that puberty range. And then after they get to about 15 or 16, a lot of that starts kind of coming out of the mix. These girls here were 16 years old when I evaluated them. And you're going to see two of them. You're going to see your teammate next. Boys typically kind of start a little bit later. They're normally in that 14, 15 range all the way up to 18, some mature even into their 20s. So their pains typically come on a little bit later. And when you consider that as females between 10 and 14 are starting to kind of develop, so they lose the neuromuscular connections, they get a lot of flexibility components, so you will see poor squat patterns. As that all resolves, it realigns. Then boys come in at 14, 15, and then they're having the same predicament. They have these growth spurts and patterns where their muscles can't lengthen as quick as their bones, so they have tons of flexibility and neuromuscular control. Once they kind of hit their puberty end, maybe at 17 or 18, then they really gain their strength back and things realign. So you're going to see some things with this girl's squat pattern. You see wobbly, feet externally rotating out, and you got to remember, she's a volleyball player. So, here she is. So she's a volleyball player, and so she's loading and exploding constantly. If you think about it, if that's her squat pattern right there, she's externally rotated out, you can consider what kind of stress is being put right in that medial compartment of her heel or her lower leg. That posterior tib is getting extremely stretched out right there, which means she's more likely to get a posterior tib tendonitis, somewhat like a shin splint. She's more likely to develop a little bit more medial knee pain. If you think about the presentation at her hips are internally rotated. And so if we know more about where femoral acetabulum impingement comes from, it's from an internally loaded hip, which is also the area where labral tears occur. So she could develop some really acute hip pain with everything that's going on with the squat pattern. So if she came with me pain and I saw the squat pattern, a lot of that stuff would definitely spark up in my assessment. This is her teammate. And I will say this girl had great mechanics. When she does her squat, she actually has an ankle braces on while she does her squat. So there's a little restriction there. And I'm just kind of telling her what she's going to do real quick. And you'll see her come into play, and she just kind of hands over head, perfect squat pattern. Even with ankle braces on, she's able to get down, and you can imagine what her load and explode would look like, but she's very safe and secure, where I would not expect her to have an injury simply from her jumping patterns. So here's a little fun that we had. So this is I believe he's a 14-year-old boy. What we did is we kind of took him through some squat assessment first. He came in just nice and cold off the street, had him go through a little bit of a squat assessment. You can see he instantly is all wiggly in his knees. He's having a little bit of hard time getting down into that squat pattern. Kind of took from a side view over here. Not too much in the upper body or the trunk, more into the knees and whatnot, not coming down parallel. So we get him down on the board, heels on the board. You can see his squat pattern improves with his heels on the board, so instantly dorsiflexion. Get him into a quick dorsiflexion stretch on the wall. We also address his hamstring because on further evaluation, his hamstring was tight as well. And you see that with growth spurts, hamstring dorsiflexion. We took him through a little bit of a dynamic hip flexor stretch. And then we rechecked the squat. And you can see after all that, it's not perfect, but it's better on the initial squat. So we know we targeted some muscles that definitely needed to be stretched out in a flexibility component, and we improved this squat pattern. So that's everything I got to share with you guys. I hope you enjoyed this presentation. I hope it gives you some insight on how to evaluate the squat mechanics. If you have any questions, feel free to email me. This video should be available so you can watch it at any point in time. And I would really kind of look at these videos and home in on your observation skills. They are very powerful as a clinician. They can definitely guide your treatment. And the better you get at this, the easier you will be at assessing not only squat mechanics, but all your patients with this functional task. So definitely email me if you have any questions.